Good afternoon, everyone. Welcome to the Technical Assistance Network for Children's Behavioral Health, Cultural, and Linguistic Competence Peer Learning Exchange. The Peer Learning Exchange is a webinar or monthly call with topics focusing on culture, health equity, and disparities in children's behavioral health. Topics are generated by you, individuals working in or being served by behavioral health organizations, and partnering with systems of care, states, tribes, territories, and communities. The TA Network, as it's known, is the National Training and Technical Assistance Center for Children's Behavioral Health for the Substance Abuse and Mental Health Services Administration, or SAMHSA. My name is Linda Callejas. I'm an assistant professor at the University of South Florida and direct the Cultural and Linguistic Competence Technical Assistance Team of the TA Network. Today's Peer Learning Exchange is titled Faith-Based Engagement and Behavioral Health in Urban Communities, Model Programs and Strategies. Today's webinar will explore the role of faith-based organizations in working effectively with behavioral health systems to promote behavioral health literacy, inclusion of underserved populations, and discuss model programs in addressing the behavioral health needs of children, youth, and families in urban settings. We have a number of presenters this afternoon, and before we begin, I'll introduce each one. The first of our presenters is Selena Webster-Bass, CEO of Voices Institute, a consulting group focused on well-being, multicultural consciousness, and health equity. Selena has a Master of Public Health from the University of South Florida and has over 20 years of community health experience working in a variety of areas, including medical education, organizational, cultural, and linguistic competence, faith-based partnerships, health equity, mental health, multicultural engagement, and sickle cell disease outreach. She served as a mental health educator and cultural competency educator with the Partnership for Child Health, Jacksonville System of Care for over 5 years and is a core partner of our Cultural and Linguistic Competence Technical Assistance Team. Following Selena, we'll hear from John Katoff, CEO of the Open Table, which you'll hear more about during his portion of the presentation. John is a servant leader, social enterprise builder, and former senior advertising and marketing executive with 30 years of experience developing and expanding community service and commercial innovations. As the founder and CEO of Open Table, John has spoken in the United States and in countries around the world about the Open Table story, and through the Open Table model, he has partnered with faith communities and federal agencies to support the development of a national shared purpose movement to grow the common good in communities. John recently founded the Center for Community Convening, an organization of Open Table that convenes business, faith, communities, foundations, government, healthcare, and other sectors in shared purpose initiatives. John has a BA from the University of Illinois, Chicago. John will be followed by Lynn Sherman, Director of Community Engagement at Baptist Health for Social Responsibility, where she leads community benefit initiatives that are designed to identify and address the unmet health needs in the community, set priorities, and develop strategies to improve the health and quality of life for families where we live, work, and play. It includes providing community outreach programs with faith-based partners, nonprofit organizations, elder advocacy organizations, community health education, and screenings for health disparities. She has worked in healthcare at Baptist Health for more than 30 years. Mrs. Sherman is a strong community advocate, and under her leadership, the nationally recognized Tipping the Scale Mentoring Adolescent Advocacy Mentoring Program has touched the lives of more than 1,500 teens and received national recognition. In addition to this program, she is quite involved in her community and has been recognized with numerous awards, including the Community Connection Celebration of Leadership Award. She is a recipient of the Shirley Anderson's Excellence in Mentoring Award, and she has been selected by the Jacksonville Business Journal as an elite African American leader. What keeps Lynn Sherman awake at night is the plight of local African American children, especially girls, the deterioration of neighborhoods, and how poverty has negatively impacted the lives of families in Jacksonville, Florida. The presentation will then continue with Jill Hill, who works for the Partnership for Child Health, Jacksonville System of Care on the Project Aware C grant from SAMHSA. She is a program coordinator and an instructor in youth and adult mental health first aid, and in this capacity has trained over 2,100 people in her community. Jill has also worked with various community organizations, members of local religious communities, the Jacksonville Sheriff's Office, local schools, the University of North Florida, child-serving organizations, and the Department of Children and Families, among others. Jill is a certified peer recovery specialist in Florida, a trainer, an advocate, and a certified exceptional student education teacher working with students experiencing emotional behavior disorders. In addition to mental health first aid, she has provided trainings across the country on the IDEA law, intellectual disabilities, and person-first language, among other topics. Jill is a graduate of the University of North Florida. Our final presenter is Dr. Glenda Wren, Chief Medical Officer of 180 Health Partners, where she provides executive clinical leadership for programs that address social determinants of health. The Strong Well program serves opiate-dependent pregnant women. The certified multidisciplinary Strong Well care team fills in the gaps of care and addresses critical access to care challenges that prevent these moms from receiving the care they need. Dr. Wren most recently served as founding director of the Kennedy Satcher Center for Mental Health Equity in the Satcher Health Leadership Institute at Morehouse School of Medicine. She has advocated for mental health equity for families with chaplains and faith-based leaders at various conferences and professional trainings. Dr. Wren's passion is to help create environments where individuals adversely impacted by trauma will face a path forward that makes it easier for them to recover and build a good life. She is a sought-after speaker and mental health policy advisor, nationally recognized for her behavioral health leadership. And now, before I turn it over to Selena, I just want to make a quick request for participants to please stay on at the end of the webinar to complete the TA Network survey on the presentation. The survey should only take about 5 minutes to complete, so we do ask that you please stay on and do so. Now, without further ado, I'd like to turn the time over to Selena.
Thank you, Linda. Good afternoon, everyone, and thank you for joining our webinar today. During this webinar, learners will explore the importance of faith communities and behavioral health systems of care, religion, spirituality, demographics of youth in the United States, the intersection of religion, spirituality, culture, and behavioral health, and we'll also share some community examples of faith-based and behavioral health models in urban communities. For the purposes of this webinar, we are using a general definition of faith-based organizations, or organizations that are rooted in a particular faith or religion that are focused on serving others in some capacity. Faith-based organizations have had a history of community engagement, community services, and social service involvement in communities. Community services may include providing assistance with food, utility, nursing facilities, early learning centers, counseling, support, substance use services, prison services, mentoring for youth, transportation, and other social services. Researchers Wolfer and Scher categorize congregational outreach into 6 categories: immediate needs such as food, shelter, and clothing; educational and health needs such as tutoring, health education, after-school programs; community development activities such as economic development and neighborhood associations and working with civic groups; outreach with homeless services, prisons, substance use support, and homeless populations; humanitarian efforts to deprive areas or countries when natural disasters occur; and public civic engagement such as voting education. So these are some of the ways that faith organizations work with communities. There is also a long history of faith-based organizations working with the behavioral health community to address mental illness and substance use in families. Increasingly, behavioral health partners recognize the need to include multiple community voices and partners in addressing the behavioral health needs of children, youth, and families. Faith organizations are often perceived by community members and congregants as a trusted and credible source of information within communities. And so it's critical that faith-based organizations are a part of this work of promoting behavioral health. Klutz, Horneffer, and Moore describe faith and behavioral health integration as a way of reaching people in their natural settings. Faith-based organizations are in a unique position to address some of the challenges of our behavioral health system, such as addressing the shame and guilt that's associated with seeking behavioral health services, assisting families in navigating fragmented systems, and addressing the basic needs of families. Researchers Kress and Elias emphasize the importance of religious identity development and religion, a more formalized belief system involving the supernatural, and/or spirituality, a less formalized way of seeking meaning. They describe religious identity development as a way of giving purpose to families, a source of comfort, providing guidance in navigating uncertain territories, coping, and as a point of hope during stressful or traumatic times. Kress and Elias have also conducted research on religious leaders' perceptions of working with psychologists and licensed behavioral health professionals. And they found that religious leaders' openness to collaborate is related to the emphasis on service orientation within congregations and outreach within the community, with history and trust with academic institutions and universities. And during their study, they also indicated that religious leaders made distinctions between perceptions of providers as authentic collaborators, meaning that faith-based organizations are equal partners at the table, contributing in mutual beneficial ways, both for the faith-based organization as well as for the provider. During this study, religious leaders also indicated the importance of distinguishing between clinical and community interventions. Clinical meaning providing services on site at faith-based locations, whereas community interventions address behavioral health education, mental health literacy, and faith-based support groups. Stanford and Philpott have conducted studies where they surveyed pastors and found that referrals were made to licensed mental health professionals and also offered assistance with payment for mental health services, prayers, and words of encouragement. One of the models that we can consider in addressing religion and the bridging with behavioral health systems is Bronfenbrenner's ecological model. This bioecological systems model emphasizes the child's biology, has a role in fueling development, but also the interaction of the child with their immediate family and community environment, and the societal landscape that fuels and steers a child's development. Changes or conflict in any one layer will ripple throughout other layers. To study a child's development, we must not only look at the child in her immediate environment, but also at the interaction of the larger environment as well. For some children, youth, and families, religion and spirituality is a part of that larger community environment and landscape. It is also important to address religion and spirituality or non-religious spirituality identity with children, youth, and families because we want to make sure that we are holistic in honoring and respectful in our approach and understanding the cultural context of families. So as a cultural consideration, providers should conduct cultural discovery, strengths, and needs assessments among children, youth, families, and identify specific ways to include culture as a part of their care plan. For example, faith leaders could serve as a natural support on a wraparound team. Faith leaders could serve on a health equity committee, providing community history and perspectives on services. Synagogues, mosques, church, or spirituality centers could serve as a safe space for a care coordination meeting or substance use support group meetings or parenting education. The next few slides include data specific to American youth in terms of the role that religion plays in their lives. So this particular slide, which shows the period of time from 1976 to 2016, the title of the study is the Child Trend Study, Monitoring the Future, a Continuing Study of American Youth. We see that since 2000, the study shows a decrease in youth that reported that religion plays an important role in their lives. And some scholars suggest that we see a decrease in religious affiliation overall, but an increase in spirituality individualism, and seeker religion orientations or spirituality orientations. On this slide for 2015, we see that 30% of 8th graders reported religion playing an important role in their lives as compared to 30% of 12th graders and 26% of 10th graders. This next slide with the child trend study shows more females reporting religion playing an important role in their lives across all grade levels, 8th, 10th, and 12th grade. This slide shows religion as an important role in the lives of youth by race. In 2016, the child trend study for 8th, 10th graders, African American youth reported religion playing a very important role in their lives, more than so for white youth and Hispanic Latinx group across all grades. For 8th graders, 31% of non-Hispanic whites reported religion as a very important role in their lives compared to 20% of Hispanic youth and 46% of African American youth. For 10th graders, 23% of non-Hispanic whites reported religion as a very important role in their lives as compared to 43% African American and 22% Hispanic American. So we can see that we see a much higher percentage for African American youth in terms of the importance of religion in their lives. So with this type of data, this is an important reason that religion should be addressed in terms of working with our families within systems of care. We should use a comprehensive, coordinated approach that includes multiple multicultural partners from various community sectors. This particular figure on this slide, developed by researchers with University of Nebraska, shows that faith organizations should be included in systems of care along with secular service providers, public and private funding, regulatory agencies, and support service agencies as well. And these are some of the faith-based assets that organizations can offer systems of care in terms of addressing behavioral health equity. Faith organizations may serve as an asset in public education, increasing mental health and substance use literacy, and the development of coalitions and advocating for social change. Also, faith organizations can offer up meeting space for various behavioral health meetings or health equity groups. And also, faith-based organizations are partners in linking families to formal and informal providers. Some faith-based providers or organizations may be closer in physical proximity to underserved populations. This figure developed by University of Nebraska researchers is a faith-based behavioral health model shaped like a pyramid, showing 3 areas of behavioral health and faith-based integration. The top of the pyramid represents clinical care and treatment, such as outpatient treatment, residential treatment, crisis intervention, for example, hotlines of trained volunteers under the supervision of professionals. And typically, we see less faith communities participating at this level because of regulations, accreditation standards, and it's much more intensive and involved. The second level is the support services level, which involves housing, for example, the homeless or individuals with substance use and mental health challenges, independent living skills, care coordination, financial assistance, transportation, GED programs, and support groups. And the final category is information services. So this is where faith-based organizations can partner with behavioral health systems in navigating the maze of systems, whether it's behavioral health, foster care systems, the educational system. Faith-based organizations can provide basic and complex referrals to behavioral health agencies and social services. And also, there are some faith-based organizations that participate in home visitation programs, for example, to educate mothers or parish nurses that may partner with various organizations and programs to address early learning or risk factors for new mothers. And then faith-based organizations may train community health outreach workers for family skills training as well. So this framework developed by University of Nebraska researchers provides possible points of connection for faith organizations and behavioral health organizations to partner and to bridge services. Behavioral health organizations provide expertise to treat, while faith-based organizations can provide opportunities for support, hope, recovery, and a journey to wellness. So we'd like to get a sense of your connections with behavioral health organizations, both from the faith-based perspective as well as from the behavioral health provider perspective, or even as an academic institution or community-based organization. So if you could participate in our poll, are you representing a faith-based partner, a behavioral health provider, an academic institution, or a community-based organization, or other? Okay. All right, we see that most of our participants on the call today are community-based organizations and behavioral health providers. About 15% of our participants, it's changed on me, but about 12.5% of our participants are faith-based partners, so mainly community-based organizations on our call today, so thank you all. Next question. Are you a faith-based partner or provider located in an urban, rural, suburban, or other setting? So we'd like to know what type of community you are working in. Is it urban, rural, suburban, or other? Okay. So it looks like most of our participants are from urban communities. 47% from urban communities, almost 16% from rural communities, and approximately 32% from suburban communities. Great. So most of our examples today that you'll hear from our co-presenters are from urban community settings, because we're specifically focusing on urban populations, densely populated areas. Next question. And this question is specifically for faith-based partners. How many faith-based partners participate in behavioral health community education? And you can check all that apply for this particular question. So the first is participating in behavioral health education, coalitions, partnerships, and health equity committees. How many faith-based partners actually are linking congregants or community members to behavioral health services? And then how many faith-based partners offer behavioral health services at your site or place of worship? And then all of the above. So you see most of our participants are, yes, referring community members to behavioral health services, so making that connection, that bridge between the behavioral health system and the faith-based organization. That's wonderful. 50% of respondents are participating in community education, increasing mental health literacy or substance use literacy in their communities. Almost 40% of respondents participating in coalition and partnership. So actually part of the planning process, analyzing data, and almost 16% are actually offering services at their site. All right, our final poll question, this particular question is for behavioral health providers, and you can check all that apply. How many behavioral health providers or other entities, so it may also be an academic institution or university setting, are providing behavioral health community education, building coalition partnerships and or health equity committees, linking community members to faith-based support services, so this is the other way around, providing on-site behavioral health services at places of worship. All right, so our results show that almost 79% of our participants are building coalitions, so you are actually working closely with faith-based organizations. 62% are providing behavioral health community education in collaboration with faith-based organizations, and 33% are actually linking community members to faith-based support services. And only a few, about almost 7%, are actually providing on-site services at a faith-based location, and 13.3% all of the above. Thank you all so much for participating in our poll. There's a question about gaining buy-in from faith-based entities. Right? So I think one of the important things in terms of buy-in is making sure that when systems of care are approaching, representatives are approaching faith-based organizations, that they're very clear about the objectives and that there's actually some mutuality in terms of coming up with agreement around specific goals and objectives in terms of working together. I think it's important to not have hidden agendas, particularly if you're a research institution, being clear and upfront about what the expectations are, and also compensating faith-based entities for their time, for their space. We compensate, other community partners, but oftentimes community-based entities or faith-based partners are not compensated for their time and their contributions to planning and coordinating and coalition building. So I think it's important that, faith-based entities are invited to the table and that they are compensated in some way for their participation and their offering of expertise. I also think it's important to convey the value of behavioral health to faith leaders, whether that's through, and we'll hear more about this, through educational programs such as youth mental health first aid, adult mental health first aid, the value to the congregants as well as to the community at large. So, showing the benefits both for the congregants as well as for advancing equity within communities. Okay. So next we have John Katos, CEO of Open Table, as our next speaker. John, we'll turn it over to you.
Thanks, Selena, and you could advance the next slide, please. So good morning. Thanks to everybody for attending. Thank you, SAMHSA, Systems of Care, and the TA Network for supporting, encouraging, and helping to pioneer effective faith-government partnerships. Thanks to the Voices Institute for organizing this, and all of the faith communities and community organizations that are part of this today. What I'd like to do is just to share some learning from our 15 years of working with faith and government communities and partnerships through the Open Table model and other models, as well as the about 6 years that we worked with Systems of Care and transitioning young adults and families coming through wraparound, and now just starting to work with the Family, Youth, and Services Bureau of the Administration for Children and Families, starting to look at the same kind of partnerships to help serve runaway and homeless youth. This slide is here to share my personal story. I'm a member of a faith community, and I drove by people experiencing poverty all of my days. I was indifferent to people with complex needs, not because I didn't care, but because I had no idea what to do. And so I think the most important thing in starting to approach faith communities is really understanding that the community at large doesn't know what to do. They don't have the solution that you do. Systems of Care and wraparound are a bold solution to significant social challenges that we face in our communities. And I'm a really strong advocate of when we go to faith communities or other community organizations to say that we are bringing a solution. The moment that we say that we're bringing an opportunity to participate or something that you can do, we start to compete with thousands of different participation opportunities and things that we can give or collect, and we'll be lost there. one of the things that I think it's important that I always ask or try to ask in meetings with our faith communities is, are we helping the people we serve to develop the lives they envision for themselves and their children? And it's a hard question for all of us, but I know that in a lot of faith communities, people will say, no, we're not. We don't know how to do that. You have a solution. Systems of Care is a powerful transformational solution. When we come to the table, it's so important to say we have a solution that can be made better and more effective if we partner in it together and not a program. Next slide, please. You know, it's so interesting. It happens in my own congregation where someone will have an idea, someone will come with a project, and you'll always hear, and I'm sure it's possible in other organizations that we're all involved in, is that people will say, well, 20% of the people are already doing 80% of the work. We don't have time for anything else to do. We're really sorry, it's not possible. And when we speak to congregations, I think it's important to say, give us the opportunity to talk to those 80% who are participating. I think we want to help try and change the orientation that it may be possible that 80% aren't pitching in because there isn't yet something that they want to do. And so if you approach a congregation, don't ask for decisions right away. Say, hey, could we go talk to a small group? Are there some people that might be interested who could guide us, who might be able to help us think through how to apply this? When you're talking with leadership at a congregation, what's going through their mind immediately is, how will we implement this? Who will implement this? Is there training for this? What will this mean? And when you talk to leadership, the thing that they want to identify, like in any organization, is a champion or champions. And so take the approach of sharing information, looking for smaller groups of people, sharing what you have, and kind of taking the view that we're about looking for and developing champions. But the other piece of this, too, that I think is so important is starting to build as behavioral health leaders in your community. Just calling and inviting a faith leader to lunch, starting to build a discussion-based relationship of getting to know each other and what your paths are. If you could allocate some lunches to that every month, the relationships that you'd be able to develop and the access to resources would be significant. So we have a bold solution, but it's so important to take the time to build and look for relationships. And if you're saying, I don't know anybody in a faith community, well, the person who is one office down or a friend or a family member, you will find those connections, and they are always the best door openers. Just the other reason that I have this picture of an empty worship center is because when you go talk to faith communities, when you become involved in those relationships, you're involved in the whole community. That worship center is occupied for a couple hours a week, and then everybody goes into the community. They go into business. They're your dentists. They are participating in civic organizations. And so don't get locked into thinking this is just faith community, because people who are in the faith community don't live that way. They don't live there. And so everything that we do starts to have a bigger view of being in the faith community and then empowering people in the faith community to bring the message out to larger audiences. We're training the open table model in healthcare systems, businesses, banks, not because we thought it would happen, it's because people in faith communities brought it out. And Open Table itself is a community organization now. There is significant faith-based participation, but I think that you could ask any faith community about their vision for helping people, and it would be the whole community becoming involved. Next, please. I apologize. Next slide. Thank you so much. Well, I just wanted to put up the competition, and that to understand that transactional responses to people in need are what dominate most of the time, that still that faith communities across the country invest in how they transform their community. The faith communities on this call are already far beyond this energy bar, but you do find it all around the country. And I think that one of the things for systems of care to think about, you know, certainly it's bringing a transformational opportunity to congregations. But to me, the big news in the community is that transformation works, that people are able to move ahead and have better lives. That is the great news that we can bring you, that it's possible, that it's real, that there are real outcomes. The energy bar doesn't have to substitute for what you want to do in your heart, but this is all that you know how to do. And so I think systems of care, part of what you're bringing is a reorientation about the possible. And the possible is that people can lead better lives. And when you bring that message to congregations, people are going to cheer that because that's what they want too. Next, please. Boy, there are a lot of resources that are involved in transactional and fragmented responses in faith communities and other community organizations. I put this up here not to bemoan it, but just to say that the resources that are available to systems of care by building these kind of relationships won't run out. There are congregations in urban areas that have million-dollar mission budgets that they invest every year in community programs. You know, one of the things going on at Open Table is starting to think about early on building these relationships with the view that the faith community and other sectors of the community will be the sustainable funding for systems of care as grants move forward into their final years. The funding is there. What kind of relationships can we build in advance to be able to sit at the table and say this is worthy of a large part of that funding? Next, please. Systems of Care has done something that I know our congregation never did, and I know that a lot of congregations that we talk to haven't. We rarely ask the people we give things to what they need. And Systems of Care is all about helping people to get where they need to be and asking them what their needs are. And that means that you have data. And that data is really important to come and help congregations understand what the needs of people are. Often life becomes so transactional that we really disconnect from this idea that people do have transformational needs. And so coming to the table and sharing that data is something critical. People in congregations will not be afraid of data. They want data. They want to know what works. Next, please. This is Ernie. Ernie and I, he is a man that I met on a mission trip down to a shelter. I didn't know how to help him. I was a business person, and I started looking for the transformational support that we had in our congregation. And I realized that what Ernie needed was relationship. He wanted to have relationships with people who would support and encourage him, and I realized that I wanted my relationship with him. Once we had that, we were able to solve all the other issues that there were, helping Ernie get his truck fixed up, helping him advocate and connect with healthcare, opening doors to job opportunities. We had everything we needed on the community side to help support Ernie. But more than that, Ernie was the beginning of the understanding that long-term relationship is really what models need to be about. Ernie and I have been in relationship for 15 years now. Our data says that the relationships that people form an Open Table with those they serve last a number of years. Building a long-term set of natural supports in the community is what can help all people develop. Once relationship is in place, all the goods and services that can help support somebody's plan to build their better life can travel through that. Next, please. I always talk to congregations. It's so interesting to say this is the bridge that the systems in our country and the people in it who have been able to build to help people return to the community. This is their half of the bridge. This is the clinical part of the bridge of helping people get ready and become stable to enter into the community and lead the lives that they envision for themselves. Because many people in the community think that the system is supposed to build the whole bridge, and so they haven't shown up to build that next half of the bridge. The next half of the bridge is relationship and the access to social capital that we all have. Relationship to be able to be encouraged and have supports, and then access to all of those things that are needed to build productive lives. And I think that that's the message. And when you bring it to faith communities and communities, people are excited because it's real work. It's not transaction. It's building a transformational path in relationship with a best practice model like systems of care. Next, please. This is what the Open Table model looks like, and there's a lot of information on the website. But Open Table is a small community of people who gather together and are trained and partner with an individual or a family in systems of care, primarily transitional youth. The youth, like Wraparound, develops their life plan. They have full voice and choice, and that community of people stays together for a year in relationship and providing access to social and intellectual capital to help that life plan move forward. The data we have says that these relationships last at least 2 years longer in most cases. Next, please. These are examples of what tables do. They help people get transportation. People who are ready to start working or go to school, they resource cars. They resource mechanics. They open doors for jobs. They advocate with youth and families and help them get the skills of advocating. They call experts, like on our own tables, we'll call a system of care saying, can you make a connection to a service? They look for housing. They find housing. They support housing, but most importantly, they provide relationships. Open Table is kind of a genetic copy of the things that have happened in our lives, the people that have come along to help us and have intervened and given us relationship and social capital. That's exactly what tables do for people in the community who don't have that kind of support system. Next, please. So this is an example of 100 people in a congregation of what is available to be resourced. Probably 1,500 years of college and technical training, about 3,000 years of life skills, and about 5,000 direct connections in the community. Jobs, dentistry, childcare, cars, mechanics, whatever is needed in the community can be accessed through that social capital. And so for the systems on this call, step back and, you know, so often we think from a perspective of scarcity that we can only have these services. But when we step out to look at the potential of the faith community, man, we're thinking about the abundance of services and connections and opportunities that are available. And because we have a solution, that's what we should be thinking about. Next, please. One more slide. And one more. Just two very quick urban examples about how systems of care have unlocked this support. In Erie, Pennsylvania, the system and the business community held a breakfast for community business leaders about Open Table and youth. 450 business owners attended that, and they are now putting together a database of individually owned businesses and executives in businesses where a youth who has an interest in being in that career path can have a mentor and shadow that business owner or executive for a day and start to develop a relationship. Finally, youth who have dreams about being something can go spend a day being that because of the social capital in that community. In Richmond, Virginia, there was a young graduate from Open Table who had a very good table, continued to have relationships. She sent a thank you card to someone in Open Table, and it was a self-designed card. As a result of that, she and her table, even though the table is over, have developed a holiday card business. She has an attorney, an accountant. She has funding to purchase cards. She will probably make $2,000 to $3,000 this year because her human potential got developed because people in a faith community saw that and encouraged it. And I think there can be 1,000 of those stories in urban areas across the country. What I want to leave you with is that it's so important for systems of care to be bold and to begin these relationships and to invite the human, social, and financial capital in faith communities to be invested in your work because your work works. I'd like to introduce our next speaker and hand it to Lynn Sherman. Thank you, Lynn.
Thank you, John. Hello, everyone. I apologize for the delay. I want to thank everybody for participating in this webinar today, and I appreciate the opportunity to share my work as others have shared so far as part of this webinar. I'd like to just start by just describing our faith-based partnership. It's a partnership between Baptist Health System and interfaith organizations and other nonprofit organizations in our community aimed at developing person-centered health care. Our faith-based health networks are successful for us in part because they accept that conventional medical care cannot meet all the needs that patients have, be it medical, psychosocial, environmental, cultural, or spiritual needs, that we're just not equipped to do it all. And but in partnership, we can work together to change things. These networks consider mind, body, and spirit in a circular approach as opposed to a linear approach. Our goal primarily is to build healthier communities and strong relationships between Baptist Health and our local faith community. We work together always to provide health literacy, health programming, and connect congregants with primary care. That is our focus. We provide annually, as part of our faith-based partnership program, we provide an annual Faith and Mental Health Conference. And it is a very robust conference focused on mental health in our community. We found that it was primarily needed because faith and mental health has its own traditions. It came to be a very integral part of what we consider the healing process. Our experts, speakers, and panelists share information on inspiring stories. The data indicates that 1 in 5 families in our communities are dealing with a loved one or themselves who are suffering from a mental illness. We discussed how to approach various things during this conference. One of the things that we're careful about doing is careful about the subjects that are covered in our conference, and that is subjects such as spiritual and addiction, and do I need help, or do I need Forgiveness is one of the topics that we discuss, and we know how stigma works and is associated with addiction and with alcoholism. Spirituality certainly plays a large role in recovery from addiction, be it alcohol, be it drugs, and the impact of spirituality in prevention as well as treatment. We discussed the resistance to seek help as a result of people who are dealing with these issues. We discussed how different faith organizations approach supporting people with mental illness and addressing stigma. Also, we take a look at the role of the faith community in reducing stigma and encouraging people to secure professional help, including encouraging faith organizations to host mental health first aid classes within their churches. We also take a look at the approach of incorporating faith into clinical services, including adhering, of course, to HIPAA regulations. And there are so many concerns in our community when it comes to isolation and depression and dementia of seniors. We call that the senior trifecta because one many times come along with the other. Because the impact of isolation on senior health it can be very challenging in families as well as in the faith community. I probably should have asked somebody to advance my slides. They're not advancing very easily. So we realize that there is a gap in faith and mental illness when it comes to just simply the lack of awareness of support systems and resources in our community. So one of the things we created was a toolkit. It's an electronic toolkit, and that toolkit is designed to help children, adults, and clergy connect to local and national resources for mental health. It could be the initial introduction for members of the faith community to get just a simple description of some of the signs and symptoms and where to go for help. And it's a trusting source because as opposed to just having them search the internet without knowing whether or not the source is one that they can really trust. Some of the support and training resources for children and adult and clergy are health options, links where they can find mental health organizations, places where they can find support groups, peer-to-peer, families who are dealing with the same challenges. They can also find treatment centers, crisis lines, suicide hotlines, and the importance of being hopeful as they navigate through their challenges with mental illness in their lives, or whether it be a family member themselves or even another congregant. Our community health needs assessment, which we, along with all other nonprofit hospitals, are regulated to do every 3 years, identified mental health as a major health priority in 4 of Northeast Florida counties. The Jacksonville Nonprofit Partnership, which is made up of 5 of the local nonprofit hospitals, do this community health needs assessment together in partnership. We actively look for projects to work on together so that we can do more than just make a small impact, but something that we can do together that will make a large impact on the community. In 2016, our community health needs assessment revealed mental health as a major health priority in our 4-county area. Mental health was significantly identified, and so what we set out to do was to train 10,000 people in our community in mental health first aid, and this is adult mental health first aid. In addition to our city organizations such as our Jacksonville Sheriff's Office, who committed to not only training facilitators, they committed to ensure that their facilitators would train all 4,500 of their staff members at our Jacksonville Sheriff's Office. And also our fire department followed suit to allow us to do that. Our faith partners opened their doors. They were ready and available with open arms to allow trainers to come in and provide mental health first aid for members of their congregation. We continue to do that. We continue to provide mental health first aid training that teaches participants how to help someone who's developing a mental health problem or experiencing a mental health crisis. This training helps you identify, understand, and respond to signs of addiction and a mental illness. And as you know, many people in our community are not quite sure how to respond to issues of mental illness when they find themselves faced with it. This is some of the data. This is just a look at where we are with our mental health first aid training. We have already trained almost 6,000 people in the last year and a half in our community. We have a goal, as I said, of 10,000. We believe that we're going to reach our goal without any challenges at all. And not only is our hospital committed to mental health first aid training in the community, they are really interested in making sure that people in our faith community not only get this training, but also services after the training is complete. And we're really excited to be able to offer that opportunity to them and to just give you an idea of how dedicated these organizations are. They have reached out, all nonprofit hospitals have worked together to pledge $900,000 to support mental health nursing, the nursing program at our University of North Florida, and also funding that was established to establish an endowment professorship in mental health for graduate nursing for the next 5 years. So our commitment in this community is pretty strong, and we intend to ensure that we are creating something that is sustainable. We're reaching out to more faith organizations and more faith organizations as they learn more about mental health first aid. They're reaching out to us and requesting that we come in and train their congregants. Most recently, we've developed implementation plans as a result of our community health needs assessment to address mental health, and our faith-based organizations are at the top of the list in terms of how we plan to connect, with them, and not only them, but also how we plan to connect to the rest of the surrounding community around these churches. Doing the Mental Health and Faith Conference really does allow us to keep the conversation going with mental health professionals and keeping everyone abreast of what the real issues are out there, and so that we will be prepared and know how to be prepared to address the issues of mental health in our community. As an organization, we've committed to continue mental health first aid training for the community members to educate all that we can educate, and also to eliminate stigma. We meet with our faith-based organizations on a monthly basis, and that allows us the platform, the opportunity to provide them with the resources they need, the information that they need as it relates to mental health, and to be able to answer the questions that they may have in terms of how they might support their congregants in the area of mental illness. We want to make sure that we are not just talking the talk, but we're also walking the talk, and that when we say that we're going to offer them mental health support, that we're actually going to do that, and so that we can help them navigate this sometimes very difficult system to navigate. Thank you very much. And I would like to introduce you all now to Jill Hill.
Thank you. Good afternoon, everyone, and thank you for attending and taking time out of your busy day. I really appreciate it. My name is Jill Hill. I am the project program coordinator for the Project Aware C grant, which is a community-based grant. We train in youth mental health first aid, anyone in our community. However, when we first got the grant, we did community mapping to see what areas we wanted to focus on, and through that we collaborated with organizations, developed MOUs, and started training people in various areas. So with that, we would have people come in and say, oh, you really need to come and train at my church, or you need to come and train at my synagogue. And so we started, I started meeting with different religious organizations and providing those trainings where I could. So we have had 11 organizations work with us. So some of those I trained 1, 2, and 3 times. We've had over 233 people with those organizations be trained in youth mental health first aid. However, we've had more than that because, as you know, someone comes to a class and they bring their life experience with them as well, and then they take it back to where they attend church. So it is a wonderful thing that we have that available to us. And so we have trained over 2,200 people in our community since the beginning of the grant. We have trained anywhere from nurses to university students to police officers. You kind of name it, we've gone there and trained it. And so some of the things that we do is we help people recognize what those signs and symptoms are of different mental health disorders. We help them to fully understand where the youth is coming from, because a lot of times we as adults forget what our youth was like and what the struggles we had, so we have to come back and kind of remind them of that and say, okay, now let's talk about these things. It really helps them to open their eyes as to, yeah, maybe that those are things that are going on. So it's a real benefit to our community. We've also had, because of this training, we've had over 950 youth referred for mental health services, and we have had an increase in, we have partnered with Mental Health America, and they provide free anonymous youth and adult mental health screeners. We've had the number of those rise dramatically over the time as well, so people are getting help. We know that wherever you attend, nowadays is starting to become violent. We've had churches in Texas and Charleston. We've had a synagogue in Pittsburgh, have those crises come right to their door. And so now they are wanting to partner more and more with us, and it's a wonderful thing because we look at the whole child, and the whole child has that aspect, a part of it. And so we are trying to train those signs and symptoms of mental health disorders and give them the tools they need to then talk with the youth, communicate with youth, and then help provide resources for them. We also give them a list of resources in our community when they leave, so they don't go home empty-handed. They have their book, they have their training, they have their certification, and then they have a ton of resources that we do hand out at the trainings. Some of our faith-based communities have said, how wonderful it was, great understanding, more understanding that they've never had before. When they actually have the tools and the resources at hand, it makes a world of difference for their youth when they're in their youth programs. So it has become a really valuable thing here in Jacksonville and Northeast Florida. And so, you take the child and we're going to work on the whole child, and part of that is the mental health, part of that is the family, part of that is getting connected with the community, and getting connected with the community includes faith-based groups. So that is what Youth Mental Health First Aid has done to for our community. And now we have, I believe, we have Dr. Nguyen, who is next to present.
Hi, everyone. Can you hear me okay? Hello?
Yes, we can hear you.
Oh, perfect. And hopefully you all can advance my slides for me unless I have control. So my name is Glenda Wren. I'm a psychiatrist by training and a health services researcher. I've recently had a transition in my work. I was the founding director of the Kennedy Satcher Center for Mental Health Equity at Morehouse School of Medicine, which I served for 7 years, and I'm still on the faculty there, but chose to get a little bit more deeper into the opiate epidemic, and I've joined a company that's addressing that for opiate-addicted pregnant women. But today I'm going to be talking about faith-based engagement and behavioral health in urban communities, specifically focusing on the value of cultural brokers, and then speaking about one of the programs that we developed at Morehouse School of Medicine that continues to be in sustainability mode. That is an example of one way that we can help provide that vehicle of brokerage between faith communities and the behavioral health community. So that's really the underlying question really of today's webinar, is how is it that we can reach diverse communities? And the link on the bottom is a website from Georgetown that gives a little background on that concept of cultural broker. But the idea is that people that have specialized expertise are often thought of as that one that has special knowledge that needs to be transmitted into the community. But the reality is that communities also have specialized knowledge and expertise about their needs, about the way in which they prefer to be communicated, about who are the leaders and who are the decision makers. And oftentimes when we try to, from an academic perspective or from a nonprofit perspective, want to work within communities, we will approach a community, and sometimes the first and second person that comes and that's the most vocal isn't necessarily the person that truly represents or speaks for that community. And that's where that concept of really thinking about who's the best cultural broker for this particular community that I'm trying to reach is important. I have a quote here that's a definition from a paper that says, "I'm really and truly present, ready to help and act, and always have been." And this is actually a translation of one of the names of God. And I just think that's a really wonderful example of how that sentence itself is a broker between what we think of as the traditional behavioral health helping community and the faith community. So they're really one and the same in terms of their intention and also in terms of what truly helps. At the end of the day, 80% of what helps in the cases of mental health crises and addressing mental health needs is just being there with an individual in a non-judgmental manner that helps to foster trust and support and communicate care and concern. And that actually doesn't require a lot of specialized knowledge. So I think it's wonderful and very important to get training such as mental health first aid that helps us to have a shared language. But just want everyone to remember that we already have that shared language of human dignity that we can use, that language of human dignity to engage with our communities in dialogue and in knowledge exchange. So cultural humility is a concept that you may have heard in the context of cultural competence training. So cultural humility really is kind of an advanced interpretation of that concept that really emphasizes the importance of bidirectional communication between cultural brokers. It's a two-way street, it's a knowledge exchange, it's a collaboration, it's an empowerment that's equal on both sides. It's not just about having a target population and trying to figure out how best to communicate with them in a culturally sensitive way. That's the first step, but it really takes a posture of cultural humility in order to truly partner with, especially if you're looking at minority or disadvantaged communities. So one of the exemplars of cultural brokerage that I want to share with you is our Smart and Secure Children Parent Leadership Development Program. This was initially developed with actually an initial grant from SAMHSA back in 2011 to have a co-created parenting program that was developed with a team of specialists and experts, academic experts, as well as community members in the Atlanta area. And we had a needs assessment that was conducted from our Prevention Research Center that identified just a huge gap in collaboration amongst parents and the school system, and the parents didn't feel that they had empowerment in advocating for their children. And of course, every parent wants their child to have the best possible opportunities in life. However, if you're not exposed to knowledge in a way that you can receive it, you may reject it as just not something that applies to you. So we developed 2 programs. The first was for parents of children aged 0 to 5, which focused on healthy brain development as well as school readiness. And what's unique about this program is not necessarily the content. The content is one that you would find in any evidence-based positive parenting curriculum, of which there are many. The unique aspect is really how the information is delivered, and not just a peer-to-peer, parent-to-parent model, but a 3-tiered leadership development model where we train parents in the curriculum that was also developed by them so that the language and the examples are salient to that particular community. And once they've gone through the program as a facilitator, they have the opportunity to have additional training so that they can learn how to facilitate groups. And because this was also part of a research project eventually, they also gained other skills that became really helpful in helping to advance their own knowledge and capacity and economic viability. This is a success, and we started out in a couple of states and then got another grant to eventually expand to now it has been in 13 different states that this program has been implemented as part of a Child Health Equity Collaborative. We also got another grant to focus on the school-age population of children aged 6 to 14. What we see is that often schools were developing parent engagement programs and implementing social-emotional learning for teachers, very much important. But if the parents at home are not using the same language as what they're using in the school, you're still not going to bridge that cultural divide. We also found as though, again, this program really focused on parenting outcomes and positive parenting behaviors. Mental health was really a secondary outcome, and we did assess and measure mental health of the parents and self-reported parenting competency, as well as what the parents reported their behavioral challenges with their children were. And we saw that this program and participation in this community that was created decreased parental depression scores, increased parental competency, and also decreased parentally, the reported negative behaviors that the parents said. What we found anecdotally was that people were interacting with their children in different ways. We had several cases of autism that were identified. Again, we don't do specialized training around autism, but people were interacting with their children in a different way, listening to them in a different way, and understood, oh, this is different from the developmental trajectory that we learned about, so maybe I should get it checked out. We also had one parent who identified a hearing disability in their child. And you can imagine that if you're at home yelling at your child in their face all the time, you might not pick up on the fact that that child's having trouble hearing, but they were using some of the techniques that were taught in the class and, in fact, identified that their child couldn't hear them. So, like I said, this program has been implemented in a community-based way. So we partner with organizations and communities that come to us seeking that training, and we give them the training to implement the program and have a standardized measurement. But there's a lot of flexibility in terms of allowing them to implement it their own way. So we have many examples where it's integrated as part of a clinic, as part of a community center. And we also have several states that have implemented the program from a church. And so I think that's an example of how we can take information that we know. In this case, it was parenting knowledge, which also has to do with healthy, positive development and attachment, which is the foundation for mental health for children, and creating that knowledge upstream. So not waiting until there's a problem that presents in school, but going as far up as possible to support that family system. And although many of our participants are are women and mothers. We also have several fathers groups and are really interested in finding ways that we can engage more with fathers, as well as multi-generational families and grandparents that are caregivers for those children. So we've learned quite a bit. Have a citation for one of our peer-reviewed publications about that particular program, but I think it's a really good example about how even if you're coming at mental health from what seems to be an indirect perspective, it's so pervasive in how we experience and understand the world around us. And through this community of legacy parents, we have experienced all the adversity of death and loss and violence within that community. And what we've learned is that we've also created a supportive environment within communities and also across states where very underserved populations can now have access to information that was previously specialized or delivered in a way that was condescending and not welcomed in certain communities. So what are some future opportunities that we're working on? One of the things that we're developing is a partnership to develop curriculum for faith leaders in mental health. And one of the things that the community brought to us was the needs of transgender youth, in particular African American transgender youth that were members of the faith community but not really fully identified. And some of the faith leaders in the community also recognized this as a challenge, did not have the language to have that dialogue or their structure. And so, we know that nearly half of transgender individuals struggle with mood symptoms. Often that's related to social rejection, internalization of negative ideas about who they are, and experiencing a lack of acceptance. So we're in the very early stages right now of developing a specialized curriculum that again would be developed in that same community-based way of getting input from the stakeholders and making sure that the content we develop for training is by design salient to the populations that we hope would use it. So we look forward to perhaps giving you guys an update next year on how that work is going, but hopefully it was helpful for you to hear about that framework of cultural brokering as you apply that to the work that you're doing in your community. And I think I'm going to turn it back over to Jill.
Oh, okay. I think Selena is, Selena, are you on the line?
Sorry about that.
That's okay.
Dr. Rand, thank you. We have a question about the parenting program out of the church. Can you share a little more about how the program works and who were some of the partners that have been involved with the parenting program that you mentioned?
Sure. If you go to KennedyThatcher.org, that's the main website, and then you can find the parenting website that has a list of all the different states that we're located in. In each of the state, when we had a period of pre-implementation, they brought together stakeholders, and every state was different. So we're in Georgia, Tennessee, Oregon, Kentucky, again, it's 13 different states, North Carolina, I think, Florida as well. And they're each a little bit different based off of where those coalitions around child health equity were. But in places where the faith leaders came to the table early, there's out in Oregon that was kind of the main partner. And so they really built their implementation phase, so not just the policy work, but the implementation of the program around their faith community. So they recruited members of that church that were parents that were eligible to experience the program with our trainers and identify leaders that were interested in becoming facilitators. And that was actually an example of that faith community self-sustain the program. So the program does have costs associated with training materials. We also provide incentives for parents for completion of a certain number of sessions and provide some incentives for our parent facilitators. But often when it's implemented with an organization, that organization may use its own members to provide facilitation, for example, and so that's one way in which they are able to not have that cost, since it was members of their congregation that were essentially volunteering to facilitate the groups. So if anyone is actually interested in hearing more about it or hearing how they might be able to implement a pilot in their area, you can send me an email and I will connect you with a project director, Roy Reese, and make sure that you can have that connection.
We'd like to thank all of our presenters for sharing information about their models and practice within their urban communities. We have a list of resources here for our participants today from various resources. Some of them are SAMHSA resources, others are mental health first aid, so please take advantage of those resources. And here's also the contact information for all of the speakers if you'd like to email and get additional information about some of the programs and models that were discussed today. We'd also like to make you aware of our upcoming Cultural and Linguistic Competence Peer Learning Exchanges. Our next one is January the 17th next year from 2 to 3, and the title of that peer learning exchange is Building Health Equity and Systems of Care by Engaging Diverse Families, Youth, and Community Organizations. And then in February, we have the ACOMA project, Engaging African American Youth and Youth of Color in Addressing Depression and Other Mental Health Needs, and that's on February the 21st next year from 2 to 3. So make sure that you check in with the TA Telegram to register for those webinars, and we look forward to connecting with you. We'd also like to encourage you to take our survey to give us some feedback. We always want to make our webinars better and also learn about topics that you may be interested in for future webinars. So please complete the survey. It's in the public chat box. The slides are located in the bottom right corner of the screen, and you can download the slides from there. And we'll also email a recording and a copy of the slides to everyone following the webinar. All right, are there any other questions? If so, you can put them in our chat box. If not, we'd like to thank everyone for their participation on the call today. Again, our contact information is listed here on the final slide, as well as the SAMHSA website and additional information related to behavioral health. Thank you all and have a wonderful holiday season. Take care. Bye-bye.